So case study, Dan, maybe I'll let him back in. So case study part 1. So it's black male, 21 years old. So think about age, think about race, all the different elements that maybe contribute. Affiliated with gangs in a marginalized community. Historically, so remember his window on the world, no known father figure. So think about what that might mean in terms of affiliation to gangs within the community. Unsure of the familial history around mental health with parental links. So not sure, understands there's none with mom, but because they don't know who dad is, not sure whether or not there's any links there. Smokes cannabis, drinks alcohol, and reports that it's to forget the life. Altercation happens between rival gangs, and a young man in an opposing gang loses his life. Our case study male is eventually found not guilty. So think about the pressure, think about the stress of going through a trial, about being in part of an experience where someone has lost their life. He's incarcerated for the distribution of Class A drugs that they were caught with when they were arrested. During this period of incarceration, his mother brings a man to see him and discloses that he is his father. So this is while he's in prison. He's observed while incarcerated other inmates being raped or attacked, and on release from prison returns to gang activity. I want you to think about and just explore a bit what might be going on for that young person. So what we're looking at on this slide is 1.3. What are the relationships between black males' gang affiliation and his mental health? So specific to this case study, we're also going to explain the signs and symptoms of mental issues linked to his gang-related environment, so the contextual things. And we're also going to maybe look at 3.1, explaining the impact of violence and trauma on individuals. So not just the person involved. So key thing in this, he's involved in a gang. Think of the violence that he may have been exposed to either directly or vicariously, so secondary, in terms of maybe just observing or hearing it, and also while he's incarcerated in prison and seeing that level of violence in there as well. So take your mics off. Elizabeth, what we've been doing is we've been supporting you guys to start answering the criteria. We're updating the presentation and it will be sent back and uploaded. So if for any reason, if you submit your assignments and there are some elements that you don't capture, we've got the evidence here as well. Okay. All right. So feel free to hop in and maybe give us an example. So the key criteria I've just sort of like spoken about are the ones we're trying to answer: 1.3, 2.1 and 3.1.
And is this on the workbook?
I'm not sure if it's on the workbook, but all the criteria is on the course handbook. The workbook gives you more examples and suggestions of things you can explore. So do you want to try giving me, let's do 2.1, explain the signs and symptoms of mental health issues in a violent or gang-related environment. What signs or symptoms might you see from this young person?
It's hypervigilant.
Hypervigilance. Who was that?
Anne.
Anne. Thanks, Anne. I can't see Elizabeth, just to let you know. So hypervigilance.
High level of anxiety.
Sorry, just say your name as well when you're...
Elliot. I just said high levels of anxiety.
Okay. High levels of anxiety, yep.
High levels of drug misuse and alcohol misuse.
And this is one of the things on the case study, isn't it?
Yep.
Okay.
Poor emotional well-being, Caroline.
Okay,
did you get that, Michelle?
Who said high levels of drug misuse?
Claire.
Claire. Thanks, Claire.
I'm going to say a lack of... Oh, go on. Sorry, Caroline.
Sorry, Caroline.
Poor emotional well-being.
Andy, a lack of identity, a lack of true self.
Bear with me. So in terms of his lack of identity, Andy, which bit of the case study might link into that?
No father figure.
Yeah.
And also maybe, you know, there's no positive role model there, is there?
Yeah.
Stressed, probably scared by seeing the attack in prison. Being raped.
Who was that? Was that
Andre.
Andre? Thanks, Andre. So yeah, that was misuse.
I said before, I don't know whether you got it, paranoia.
Who just said that?
Nikki, sorry, I haven't got my
Nikki,
microphone by my
thanks,
mouth.
Nikki.
That would help.
So,
And maybe PTSD as well from some of the things that he's witnessed.
yeah. So we're linking now some of the results of this young person being in a gang and youth violence, the exposure to violence, the trauma that they may experience, how they might then start to cope with the high levels of drugs misuse and alcohol, which Claire has said. Elliot has said the high levels of anxiety that they may experience, and defined it as that hypervigilance, that state which is often linked to PTSD, isn't it? That constant state, your fight or flight system is constantly going. Caroline said there may be elements of poor emotional well-being, and Andy said a lack of identity. So the father deficit, something that there's a lot of research about in terms of there being no father figure. And then when young people go out and actually have those behaviors modeled by those significant members in the gangs. So scared of seeing the attack in prison. Andre, do you think that there may have been a fear around it possibly happening to them?
Yeah, most definitely.
And what sorts of, sorry, Andre, what sorts of things might this person do in prison to kind of set the tone that you're not doing that to me? What sort of things might happen? Or
carry a weapon, or probably like assault someone else, so people think that he's hard, sort of thing. So people are kind of scared to approach him.
Yeah.
And form a gang as well, even form, you know, rival people that you know be around that can protect him.
Yeah. To approach him, yeah. Rival gangs. Anything else anyone would like to add? So we've been linking the experiences of this young person to the outcomes of mental health. So the risks are that they may use or misuse alcohol and drugs. The signs and symptoms we've explained as hypervigilance, high levels of anxiety, poor emotional well-being. So that emotional literacy, not being able to understand how you're feeling, not being able to maybe communicate it as well. So yeah, this is what your update looks like. Anything else you want to add, or do you think we've captured enough?
Caroline, I also think the fact of being under the influence of alcohol and drugs, they're not being responsible for the behaviour, and therefore they won't have a great understanding of the impact that they're having on people because they're under the influence. You know what I mean? A lot of my guys can't remember some stuff. A lot of the females I work with can't remember things because they were heavily intoxicated. But it's been an extremely violent assault on innocent bystanders.
Yeah.
But they can't remember it.
I was going to say disassociation or amnesia as well.
Okay, absolutely. Who was that?
Celicia.
Celicia. Thanks, Celicia.
I just thought of one more. They could possibly just present as being in denial about, you know, and almost present as obstructive. There's, you know, putting up walls. There's nothing going on. you don't know anything about me, you know, sort of how it presents as they're being difficult, but
Yeah.
actually they're just being protective of themselves.
And also self-harm or suicide. Obviously he's come out at the end in this case, but obviously like self-harm and suicide are risk factors
Right,
too.
who's sorry? I
Nikki,
can't see.
sorry, it's Nikki.
Nikki, thanks, Nikki. So self-harm. What else, Nikki?
I said suicide.
Suicide.
But obviously on this particular study, he's I've just seen at the bottom, he's since been released, but I was just thinking in a custodial environment.
Yeah, but when we're thinking longer term, it's potentially an outcome that is quite viable for these circumstances, isn't it? So the disassociation, Celicia, from the emotions, anything else? What might the disassociation be toward?
Like they might like start to desensitize themselves so much that they lack empathy because they have seen all those terrible things that are going around them, and you know, you very are much your environment half the time. So you see all these nasty things happening. What are you gonna do? You're gonna be
Absolutely.
back.
That is really, really quite common with young people, particularly those that might experience depression. They become desensitized and they use the disassociation as a way of protecting themselves. When the emotions become so overwhelming, that is how us looking in might view them as cold-hearted, not really caring, but actually they desensitize because they don't know how to deal with the emotions. Quite often when people use self-harm or suicide as ways of coping, what they describe is that it's the overwhelming emotion that they can't control, and that's maybe an outlet for them. So that's really important.
And also, they must, I feel like some of them are quite passive with it, and they can fantasize about, you know, these sort of suicidal thoughts and stuff. And if it comes to like drug misuse, a lot that can cause like drug-induced psychosis, which again,
absolutely, yeah. So lots there. And again, you guys are kind of answering these bits for yourselves. So we've looked at the case study, we've updated the answers. These are your answers, they'll be sent back to you. So looking at risk factors for gang members 1.2, the risk factors I've heard, exclusion, truancy, school dropout. Statistics are showing that since COVID-19 took place, the amount of children that were in education and accounted for is still not back at the levels prior to COVID. So truancy and school dropout, risk factors for a lot of young people that have been that have experienced COVID-19. Delinquent siblings and peers. So maybe young people seeing older siblings behaving in a way that is linked to gangs and maybe wanting to be just like them. Could be a potential risk factor. Early initiation of violent behavior, parental criminality, so a parent who has maybe gone to prison or involved in criminality, low levels of parental involvement. So we looked at the ACEs. So particularly if a parent maybe experiences mental health, they're less likely to be fully functioning if they're using maybe drugs or alcohol as a way of coping. We've said about young people potentially becoming carers as well. Anything that stands out for you? Or anything you might want to add to the risk factors? It's just a brief sort of like...
The siblings, sorry, it's Nikki again, the siblings, the delinquent siblings and peers, I think is massive. I work with a lad whose older brothers are quite heavily involved in criminality, but then when I sort of sit and discuss things with him about his younger brother, I say, how's he? And he says, I've done this so he doesn't have to, and he sees his role as protective, so that him getting involved in it and to provide for him so he has everything he needs, so the younger brother doesn't have to. And I think there's sometimes that pressure from the other aspect as well. He's been on he's been in that position and he doesn't want that for his younger siblings too.
And there is, and we don't recognize them as carers, do we? but we've got a few statistics just about carers. When people are caring, they are for others, they are normally unpaid. So normally will have all the responsibilities and be carers as well. And they're less likely to get the respite, so the break from caring. But imagine just being a young person and having that as a responsibility, and then going out, being involved in gang activity so that you can kind of make ends meet to buy milk for your younger siblings and things like that. Huge weight on your shoulders. Huge weight on your shoulders. So 2.1, we're looking at the mental health statistics and the criteria. Explain the signs and symptoms. So psychotic disorders, 0.7 in 100 people. Suicidal thoughts, that's more than like 20%. Again, suicidal thoughts is much more common than the figures around self-harm or suicide attempts. People often experience suicidal thoughts. They can maybe come and be quite persistent. They can fade away if we put things in place or get the support that we need, and be quite dormant, and not always there, but they are more common. And we'll look in, I think, session 2 in a bit more detail of these sorts of things. But just to give you a bit of statistics, so 1 in 10 young people experience a mental health issue at any one time, and suicide is the leading cause of death for those between 5 and 19. Quite often, they may experience suicidal thoughts, use self-harm as a way of coping. Anyone that uses self-harm as a way of coping is 49 times more likely to end their life by suicide. And that's just because of the way that they cope, and it puts them at a higher risk. So anyone who is using self-harm as a way of coping is automatically more at risk. Describing the management and treatment approaches that may be used in mental health. So again, some of the young people, some of the mental illnesses faced by them, based on what we've just seen as well: antisocial personality disorder, anxiety, really quite common, and it's probably one that slips under the net quite often because people don't recognize it. The feeling that they might get, they might normalize and not really bring it to the forefront. Psychosis, where they may eventually have that break in their mental capacity from reality. PTSD, post-traumatic stress disorder, probably one of the most common that you're going to be aware of. Suicide attempts, that was something mentioned in the video as well. So the use of self-harming behaviors might be something that is going to be happening quite frequently in various different ways. We spoke last week about drinking alcohol probably being the most socially acceptable. We can go out and purchase alcohol. We don't really take into account the physical damage that it does internally with excessive drinking and not being able to process that through our bodies. The alcohol dependency. Okay. So looking at antisocial personality disorder in a bit more detail, it affects how people can think, how they perceive, how they feel, and how they will relate to others as well. Characterized by impulsive or irresponsible and often criminal behavior. One of the things we mentioned last week was about young people and some of their quite erratic or harmful behaviors. So potentially some of our young people fitting into this category. Someone with antisocial personality disorder will typically be manipulative, deceitful and reckless, and will not care for other people's feelings. So what we might see or observe of them, we might feel that they are disconnected from other emotions, etc. And it affects men more than women. So there we're covering our 3.3 as well. Why do we think it might affect men more than it does women?
Because men and boys don't talk about their feelings.
So don't maybe talk about things more, so it's maybe just built up. So criminal behavior is a key feature of antisocial personality disorder. Was it you, Anne, that talked about the young people potentially wanting that buzz. I think it was you, Elizabeth, wasn't it? You said that sometimes the things that they do, they want to get that buzz back, and this could be linked into that, just in terms of it being, move this on here, just in terms of that being a disorder. So again, both genetics and traumatic childhood experiences such as abuse or neglect. So some of the people that were just in that video would have been maybe exposed to some of these different things. Often they may have grown up in difficult circumstances, and one or both parents, so often the ACEs of an adult or parent at home coping with alcohol or drug abuse, parental conflict, so DV, domestic violence, really important, changes in legislation so that young people that are maybe observing domestic violence, they are now considered victims in their own right under new legislation. Harsh and inconsistent parenting can be common. So maybe the father deficit, that was kind of linked in with our young person that we did the case study on last week. Father was absent, new father brought in quite late on, and maybe some of the disruption that that might cause. As a result of these problems, there may be frequent social services or local authority or other services just interacting with families. Behavioural problems a lot during adolescence and adulthood. So going into schools, what we might hear is young people have behaviours. So it's really important to kind of ask for specifics when people mention behaviours. So the language that we use, how we document young people's behaviour is really, really important. So again, linking into that 2.1 and 4.1, anxiety or generalized anxiety disorder, probably one of the most common in terms of what young people might experience. We can experience anxiety on a day-to-day. Disorders will typically mean that they are experiencing this anxiety or whatever the disorder is to a degree that it is impacting their day-to-day life. So that's sort of like the key sort of trait of a disorder. They will have experienced it for a minimum of about 4 weeks, and it might be ongoing. So various things: increased heart rate, jelly legs, hyperventilation, so that dry mouth, maybe feeling like they can't breathe, feeling sick, nausea, tension, headaches, shaking, palpitations. So anxiety attacks might feel or mimic like a heart attack, people often report. So just double checking whether or not young people maybe have any underlying conditions would be quite useful to do as well. So knowing your young person is going to be really, really important as well. And again, you'll get the slides. So behavioural symptoms, maybe avoiding situations. So if you've got young people that maybe isolate a lot, quite often you might find that you're talking to a young person and it might almost seem like they're vacant, not responding. Sometimes they may be actually trying to focus on controlling their anxiety, and that might be what is presenting with that blankness or unresponsiveness that you might get. The anxiety often returns the next time they're in that situation. So it's quite useful if we're able to help the young people be exposed to those situations and deal with the emotions as they come up rather than trying to shut them away. So psychosis, probably really sort of key. We mentioned psychosis can be brought on by a urinary tract infection. So it's quite often something we find in elderly people. But it's where someone will lose contact with reality. It's an umbrella term for things like schizophrenia and bipolar. So they may believe things are true. Young people might be in the delusional state that maybe someone is maybe following them or after them. How do we then muddle through that if they are linked to gangs and that actually could be a reality for them? The hallucinations, where a person hears and sees something. We've mentioned that they may hear, see something that isn't there, and that's the key factor. The hallucination means they are experiencing things that are not there, so wouldn't be visible by others that are present. Imaginary friends. So young people that have imaginary friends, if we've maybe thought someone has called us, heard the bell ring, all those sorts of things. Quite often, some of the hallucinations might be voice hearing. So they may have voices that are maybe commanding them, telling them to do things, harm people. They may hear voices that are maybe saying derogatory things to them. Again, you may experience someone talking to themselves, but it's a fine line. I think with all the technology and earpieces now, it's checking whether or not someone's actually got something in their ear and they are on an earpiece, rather than it being these sorts of symptoms. So technology puts that extra barrier of us maybe finding those sorts of things out. The delusions may be strong beliefs that are not shared by others, believing that maybe there's a conspiracy. So again, a key thing that we may struggle if we don't know a history of a young person involved in gangs and youth violence. They are saying that someone is after them. It might be that if they are experiencing that, if they are connected to gangs, it might be true, but it might be that if they are becoming unwell, that may have been past behaviour and part of their unwellness. Has anyone worked with a young person that has maybe experienced the anxiety, psychosis, any of that?
I worked with one young boy, and some of his symptoms for psychosis, like I've literally just wrote it down, because when he mentioned that he hears like voices, and I didn't know what to think of it, but this has gave me, I guess, a definition of, so it might not be completely, but it's something that I've wrote down in my notes as a possibility.
Voice hearers, it just depends. Sometimes they can be commanding them, and I think key things to kind of look out for might be if they start, a delusion might be that they might start thinking about religion. A key thing to maybe explore would be if they were maybe concerned with religion before this period, where they maybe have an intense sort of focus on it. Sometimes they might say that, I don't know, someone has told them to do something, so they might be hearing commands. I'll come to you next, Alicia. So they may be hearing commands. I work with a colleague who actually does research around voice hearers, and how she describes it, it's literally like you could be having a conversation with someone, but you've got someone sort of in your ear talking to you about something. So the answers, what you might find is that they may either be talking to themselves, so sometimes they might be telling the voices to shut up, go away, or they may be having that full-blown conversation with the voice that's there. Not all of them will actually see someone, but they may just hear voices. But yeah, I'm just imagining just having a conversation, a two-way conversation, and just constantly having someone in your ear. That's kind of how she describes it. And also that it's normally that you maybe learn to kind of do day-to-day things with that in the background when it's at its worst. For some voice hearers, it will be quite prominent at times, and when they're in well states, then it will be sort of like a bit reduced. But some people describe it as always being there and almost having to manage it by drowning it out with other things. Salisha?
I don't know if this is like a question for a doctor or but you might be able to answer it. You know, when people, especially young people, can hear voices, and say that they're getting help, they might be on medication even. Will they always permanently have that problem for the rest of their life? Or have you ever heard of like people say, I used to hear voices in my 20s, for example, and then it went away? Do you get what I mean?
Yeah. So I was just saying, sometimes people describe it as it maybe being in the background. When people are more unwell, then their symptoms are more prominent or more acute. When they are maybe medicated or have a good lifestyle and aren't worried about things, then they kind of subside, if that makes sense. What I would say is it's often that it doesn't just go away like a cough or a cold, but it's maybe something that they live with. So I would say think of like mental health and the impact of psychosis or the unwellness as more like when we are dealing with addiction. When people abstain or the cessation of smoking, you are constantly working on keeping well or staying off the drug or whatever it is. With mental health, it's that consistent sort of like state of changing lifestyle, eating well, all those sorts of things that keep you well. It's maintaining those things. So if someone experiences bipolar, for example, they may have the low where they are in the depressive state, and that could last a number of years. But when they are well, they might not experience the mania of the high or the low, but they will still have the condition. So the fact that they have had that diagnosis is what makes them protected in terms of the Equality Act for the purposes of a disability. So they may be freer of symptoms of their diagnosis, whatever it is, if it's psychosis, bipolar, schizophrenia, but there's always the potential that it can come back. So I think, answering the question in full, they may not hear voices consistently. It may subside or maybe be in the background or not as bad, so they're able to function daily. But it's something that could reoccur. Does that make sense? Or does it answer your question, Salisha?
Yeah, no, you kind of like that illustration of thinking of an addiction like cigarettes and nicotine, or even higher classes. Yeah,
Cessation, and it's staying well, isn't it? It's doing all the things. But young people in gangs and youth violence, they are potentially people that are going to have a lifestyle that will keep them on a road where their unwellness will fluctuate. And key things that we've got to consider is they probably won't access the GP surgery as often as others, dentists, so their general health is going to be impacted as well. Okay, so losing touch with reality. Psychosis triggers traumatic event. When we think of the context of gangs and youth violence, that could be just their day-to-day sorts of activities. Stress, maybe the pressure of the induction into the gang, them having to do something that they may be not comfortable with. Drug misuse, alcohol misuse. And when we use the language misuse, young people might use drugs or alcohol just in terms of socializing, so they may not consider it misuse. And quite often young people that use drugs or alcohol aren't really aware of the impacts or consequences that it can have. Side effects of prescribed medications. Some of them, a lot of the medications prescribed to treat anxiety, depression, so your antipsychotic meds, a lot of the side effects will be the reinforcing elements. So it may increase their feelings of sadness, it may increase their suicidal thoughts, but it keeps them well. So those are some of the key reasons why people will disengage from medication. Also, it can have an impact on their libido. So it might mean that for males, they can't get an erection. For females, it might mean that they don't feel like being intimate. So a lot of those things will impact with their day-to-day life and are often some of the main causes as why people will disengage from their medication and become unwell again. So a physical condition such as a brain tumor could also trigger a psychosis. So if they've maybe got a tumor growing on a part of the brain that maybe controls certain parts of the body. Prodromal, so not a diagnosis, but a technical term sometimes used by mental health professionals to describe a specific group of symptoms that may precede the onset of a mental illness. So you might say, if you're aware of someone's key signatures, when they are starting to become unwell, their behavior looks like this. So that's what that means. So if you've got a young person and you know that quite often, if they are maybe unwell or in a certain state, leading up to that, their behavior and what they do will look like this. Okay. So we've mentioned antipsychotic medication. Benzodiazepines helps the body to relax. So sometimes people might be in a heightened state. So if we use bipolar, where they're in that manic state, and brain during detox, and have to have a sedative, often have a sedative effect that combat the effects of alcohol withdrawal symptoms. It can help relieve the symptoms of psychosis. So a lot of the medications are used to treat lots of different things. So sometimes someone that may present will be treated blind, so they'll be given a medication and the GP or doctors will just sort of like monitor the response to the medication, and quite often that's how they start to diagnose people based on the medications that they've maybe been given and the impact or effect that that has. So psychological therapy, so we are exploring that 4.1. Describe management and treatment approaches that may be used in mental illnesses. So we're talking about the medications. We're talking about psychological therapies, so CBT, cognitive behavioral. We look at how the thoughts may impact the behaviors, but also in terms of psychosis, it's quite useful just in terms of sometimes we may need to change the behaviors really quickly. So you might put behavioral bits in. So the local trust in conjunction with Mind run the IAPT service, so improving access to psychological therapies, and they tend to use behavioral therapies to treat. It doesn't actually treat the root cause, but what they do is they try to change the behaviors so that the behaviors change. Some of those behaviors might be that you don't tell them to stop drinking, but you might reduce the intake of alcohol rather than take it away totally, because what would happen is their body might go into a toxic shock. So maybe reducing that and replacing it with something else. So you put a behavior in so that they could change it. Social support has become really, really important. And what they call it now is social prescribing. So quite often people or services say they are holistic, say they're person-centered, but they don't consider the whole person. The support that is needed from a social perspective is going to be really important with someone, particularly if we're trying to get young people to abstain from gangs. How do they then socialize and meet those needs in connecting with each other? So it might be finding diversionary activities, educational or employment opportunities to divert them. So social support is really, really, really important. So describing the management and treatment of approaches. Drug and alcohol dependency, key, really, really important. So the dependence is a cluster of the behavior, the cognition, so the thought and the physiological factors, so how your body is impacted, that typically include that strong desire to drink. So what we're talking about there is the addiction, isn't it? Your body is used to a certain amount of alcohol. When it gets it, it sends the signal to the brain and it says, I like this. The endorphins are released. The more and more we drink alcohol, the initial sort of impact then turns into that suppressive impact. So you might get people that are maybe not thinking straight, make silly decisions when they are under the influence of drugs or alcohol, believe they can fly, believe they're invincible, and that may feed into some of that gang and youth violence behaviour as well. So in severely dependent patients who have been drinking excessively for a prolonged period of time, key example of that would be Amy Winehouse, drug and alcohol dependent. Alcohol withdrawal syndrome, which is the absence, which in the absence of medical management can lead to seizures, delirium, tremors, and also death. Amy Winehouse's cause of death was linked to the fact that she stopped drinking alcohol and her body went into shock. So quite specialist, and we shouldn't just be advising stop drinking, give it up. If people are using drugs and alcohol as ways of coping, key things we shouldn't be doing is telling them to just give it up outright, but seek medical help so that they can be supported in maybe reducing that intake and choosing alternatives. So drug dependence, again, varying in meaning. The DSM is the American version, but I think it's now the DSM-6. And the ICD-11 is now the current diagnostic book for us in the UK. Again, I'll pop that link in. to the groups for you. But basically anything, seizures, depression, anything that can be given a clinical diagnosis is in that book, and that is what they use to check the symptoms when they are going to give a diagnosis for someone. So the substance or psychoactive substance abuse is defined as a maladaptive, so an unhelpful or a negative or a broken pattern of use indicated by continued use despite knowledge of having a persistent or recurrent social, occupational, psychological, or physical problem. So quite often you might find people that are either drug or alcohol dependent. They can be quite high functioning. So I would say it's going to be dependent on the skills the social skills that they maybe have developed in terms of coping. So for example, my friend used to work in a pub, and they had, he was a judge, really quite high functioning, but he was an alcoholic. So we can often find that people in high functioning roles, when we think of like Wall Street or the financial sector, I worked in banking for a number of years. And when we took clients out, the use of like cocaine was prolific with some of the clients, and that, you know, high functioning so that they were able to do their jobs. Any questions around drug alcohol dependency, the delirium, seizures, death? So no, we shouldn't be advising young people to just give up. We should be seeking the help and support that is needed. Quite often, drug and alcohol abuse or misuse will mean that there is also most definitely some element of mental health support that is going to be required. So that might be the anxiety, it might be the depression, or something else. And when we find that they are together, we call that comorbid. So they would exist together and both be a problem. Key issues that you're going to find is that if someone turns up under the influence of drugs or alcohol, they may not be able to have their mental health appointment, because one thing that they might say is they don't have the capacity or the full capacity to consent to the treatment that they might get. So with drugs and alcohol, that is the issue in terms of getting the treatment. Quite often it's their use of the dependencies that impact them getting the correct treatment at the right time.